right, good morning, everybody. This is Michelle Dufresne, and I'm going to be covering tissue integrity with y'all today. There's a lot of content in this subject area, so I'm going to move a little fast. It is being recorded, so you can come back and review things you might not have gotten complete or ask at the end of the class today. I do tend to forget to give breaks, so somebody please remind me when it's halfway through so we can at least take a little break if I don't remember.
I'll let you know when it's 9:20.
Okay, thank you, Ms. Cook. All right, let me start sharing the screen again. Okay, so tissue integrity, like it says, love the skin you're in. So how do we define tissue integrity? It's the state of structurally intact and physiologically functioning epithelial tissue, such as the integument and mucous membranes. I'll do something here. Okay, so that's one definition that comes straight out of your book. But tissue integrity is just the intact layers of our skin, which includes mucous membranes, corneal tissue, subcutaneous tissue. Whenever there's an interruption in any area of those parts of our skin, then the integrity is impaired. This is just a little reminder of the anatomy of the skin. The skin's a very complicated organ. It is, as you remember, the largest system in our body. So just to go over the diagram briefly, the epidermis, the top layer of our skin, actually has 7 different layers to it. These are different names of cells that make up the epidermis. Underneath it is the dermis layer. And then the dermis layer is where you'll find most of your nerve endings. Blood vessels are starting to form in that area. And then underneath the dermis is what we call the subcutaneous tissue. So that's our fatty tissue. In the fat cells, you'll see glands and other things like veins and arteries also coming through. Okay. So the functions of the skin, again, more review. It's to protect the body from invasion by foreign bodies, regulates our body temperature. It does produce our psychosocial appearance that we have of ourselves and others. Sensation, it stores certain vitamins like vitamin D, and it controls evaporation of water and absorption of substances when it's on the skin. And it does have a function of elimination of waste products. So things that can affect our integrity, factors that we need to consider when we look at tissue integrity. Genetics, age, overall health status, nutritional status are the main factors that I'm talking about. So genetics, we inherit certain qualities that help us, what makes our skin look the way it looks, like the color, its sensitivity to light, allergies to environmental things, those kind of things. Age is big. The very elderly and the very young are most at risk for injury to the integrity of the skin. The elderly, as we grow older, we start losing that fat layer. The subcutaneous layer becomes thinner and less. So they're more prone to shearing and friction injuries because of that. The very young, the skin is just immature. It's not matured yet, so it doesn't have all the protective functions as we just went over. And it takes about a month before the skin is matured enough to start functioning as a protective layer for infants. Underlying health, chronic conditions, many chronic conditions can affect the integrity of the skin. And as we go along, you'll see different examples of that. And then nutritional status. The skin needs to be provided with certain minerals and vitamins and calories and proteins to regenerate and continue to be intact. Okay. So I just went over that. Medications is the other thing that can affect our skin. That has to do with chronic conditions like steroids, corticosteroids damage the skin. Antibiotics, chemotherapeutics can make you more prone or sensitive to sunlight and other environmental things can affect the skin easier. All right, so assessment. Who should do the assessment, when, how, and what to look for? This is the big screen or shot that you should keep in mind. Nurses are the only ones who can do the assessment of the skin. So you can't delegate this task to anybody. When at different times, whenever you're in the room, maybe repositioning a patient, that might be your best time to assess the skin fully, or during a bath, if it's in the evening or in the morning. Those are just examples, okay? But every time you walk in your patient's room, you should be assessing that person's skin, all right? How? So we inspect the skin folds, moist areas like the growing areas, the sacral side, pressure points. And it's important to remove any kind of, sorry, I just realized I didn't put my video on. It's important to remove stockings, braces, any kind of medical device that you can safely remove that's covering the skin. You want to look underneath those devices to make sure that there's no impairment that's caused by that device. Okay, and we want to palpate the skin for temperature, for the turgor, for the moisture also. So we look for different things. We're looking for presence of edema, any type of lesion, rash, breakdown of any kind, tattoos, piercings, odors. And to the left, you can see the example that I have showing all the different pressure points in our body. All the little red dots represent a pressure point. So the forehead, the nose, the occipital area, your earlobes on each side, shoulders, shoulder blades if they're laying on the back, the sacral area, the hip area, the knees, the ankles, the toes, heel's a big one. So any point that is going to apply pressure when the patient's laying down or sitting can be a pressure point. All right, so here are examples of what we are assessing for. These are the type of lesions that you're going to look at, and they're considered, sorry about that, considered secondary and primary lesions. So the primary lesion is what is the result of a pathological change. A secondary lesion is just the result of what happens with inflammation or infection to a primary lesion. Okay, so over here, this is an example of malignant melanoma, squamous cell carcinoma. These are primary lesions. So you would come, I keep changing it, sorry. So you would look at the lesion and decide what type of primary lesion is this, okay? This is the easier ones. This is example of a varicella rash or the chicken pox, or if depending, because I can't tell exactly, it may be shingles. These are vesicles. So vesicle bulla is one of the primary lesions. Over here is an example of an abscess forming. It's a pustule. So another primary lesion. Here's bullas, again, from some type of inflammatory skin disease. Again, a primary lesion, a bulla. So these are just examples on the far left here of the types, the names of primary and secondary lesions. So you need to start becoming familiar with those terms, because those are the terms you're going to use in your documentation as a nurse when you're describing wounds. So how do we assess wounds? We went over assessment a little bit, what to look for, where to look for. This is one of the tools that you will be using in the hospital. It's called the Braden Risk Assessment. It's a risk assessment tool. And it is, I can't think of a word, research-based, proven to be valid and reliable. So it's a valid and reliable tool that we can use to measure a person's risk for skin integrity problems. It looks at their certain areas. It looks for their sensory or perception, moisture, activity, mobility, nutrition, friction, and sharing problems. So those are different categories you're going to rate a patient on after you have done their assessments. And the criteria for each section is provided on the tool. It's not something I expect you to memorize. You know, what's a level 1, level 2, level 3 for sensation, for example. That's not the purpose of this, but you need to know how to use it. So you need to know that it measures sensory, moisture, activity, mobility, nutrition, friction, sharing. That's what the Braden scale is going to look at, that will determine someone's risk for a skin integrity problem. So who is at risk? So these are examples of people who would be at risk. Someone who's in prolonged surgery case, someone who has hypertension, someone who has a restricted mobility, incontinence, malnutrition, impaired sensation like a paralysis from a spinal cord injury, or maybe it's someone who has muscular dystrophy or muscular sclerosis, general debility, our elderly patients who are bedbound, for example, cachectic patient who's not eating. Example, saw someone yesterday in my clinical rotation, elderly lady with COPD who weighed 65 pounds. She's very, very cachectic, struggling just to breathe, so she's not eating enough. So definitely general debility, at risk for skin integrity issues. Exposure to sharing and friction, someone who can't get out of bed by themselves. The elderly, a smoker, someone in intractable pain can be at risk for skin integrity. So the Braden scale would help you identify these categories of people, okay? All right. So pressure ulcer risk, we just went over it. Here it is again. So those are the major categories that you'll see who have risk for breakdown in their skin. So friction force is acting parallel to the skin, like the sheets rubbing underneath them, removing superficial layers of the epidermis. So that's what shearing and friction does. Immobility, extreme weakness, pain, paralysis will hinder their ability to change their positions and with discomfort. And so they refuse to move. So that puts them at a risk for skin integrity. Nutrition. Inadequate nutrition, excessive weight loss, muscle atrophy, loss of subcutaneous tissue, which leads to decreasing that cushion padding that the fat provides, will increase their risk for ulcer formations and just breakdown. People who are malnourished will develop hypoproteinemia, which can lead to excessive edema, and just that edema will put them at risk also for breakdown. Incontinence leads to moisture, excessive moisture, and maceration is the term you should learn. And maceration means the tissues soften and it's susceptible to erosion and injury from that. Or incontinence can produce excoriation to the area where the urine and stools in contact with the skin. Excoriation causes erosion away of the epidermis layers also. So superficial loss of skin tissue is what excoriation produces. Decreased mental status. Anybody who's unconscious, who's heavily sedated, or who has dementia will be unable to recognize and respond to the pain signals that our body gives us that triggers us to move and shift our weight so that we relieve pressure off of certain areas. The longer you sit in one area applying pressure, the higher the chances are you'll impair the skin integrity. So anyone, of course, with diminished sensation, like we said, paralysis, strokes, any number of neurological disorders can produce a loss of sensation and reduce the ability to respond again to those signals that we would get to reposition our body, and leads to trauma to the skin, or maybe they're unable to sense temperature differences, so it can lead to burns, chemical burns, fire burns, cold, freezer burns, things like that. Loss of circulation, things like that. So excessive body heat is another example. And just excessive body heat can increase the metabolic rate that puts on the tissue to increase oxygen demand. And that can alone lead to impaired skin integrity. And then advanced age, we said they lose their subcutaneous layer, so the skin becomes thinner. That's what they mean, the skin looks thin and frail. They also lose their elasticity in the skin. So those two things decrease the strength and the cushion that's provided in the layers of the skin that make them more at risk for problems. And then our medical chronic conditions, which compromise oxygen supply and demand again, and poor perfusion leads to tissue integrity issues. All right, so assessment and wound drainage. So what do we assess? We assess not only the type of wound, is it a primary and secondary condition, but the secondary conditions are what we're talking about here. So the serous, sanguineous, and purulent discharge that can be produced from a wound, or skin breakdown. So serous is just that clear watery plasma. Sanguineous is bright red, indicates some bleeding going on in the wound. Purulent drainage, yellow, green colored looking stuff, tan, brown discharge. It sometimes has an odor, and depending on the cause of this purulent discharge, it can indicate an infection. Doesn't always indicate an infection, but it can most of the time. So we can have a combination of these three things. So you could have serosanguinous or purosanguinous. So serosanguinous is serous drainage with blood. Purosanguinous is purulent drainage with blood. Okay. We also want to look at labs. All right. So here are the major labs you would want to assess and can give you an indication of whether or not your patient has a skin integrity issue. So white blood cell count, red blood cell count, platelet coagulation studies, serum albumin, and wound cultures and sensitivities if we're doing that. So the white count, we would see a decrease in your white blood cell count. So your decrease in leukocytes would indicate a problem with healing. So if they have a wound, then they're more likely going to have problems healing that wound and develop an infection easier in that wound. Red blood cell count is an indication of their oxygen capacity, carrying capacity. So perfusion of nutrients like oxygen that the cells need to heal can indicate a decrease in your red blood cell level can indicate problems with wound healing or just tissue integrity, period. And we look at the hemoglobin count for that. Prolonged coagulation studies, those are your PTT levels, prothrombin count, partial prothrombin counts. When they're prolonged, this means it's taking longer for the body to produce blood clots. And so if it's prolonged, then they are going to bleed easier. They will have more bleeding going on in those wounds. And so that will indicate problems with wound healing also. Hypercoagulation, on the other side, means they're clotting too quickly and can produce a deficit of blood supply to those areas where the clots are forming. Albumin levels. So albumin is a protein, and it's one of the markers of nutritional status that we look for. So when your albumin level's low, it can indicate the person's malnourished or poor protein, poor nutrition, no status. And they will have a problem with wound healing again, if that's the case. And also an increased risk for infection. So the big number, the magic number is less than 3.5. So you should remember less than 3.5 is an indication of malnutrition in your patient, and they will have trouble with wound healing in that case. Wound cultures are done if you suspect of infection may be taking place. So, of course, if there's presence of an infectious agent, then there's a risk for poor wound healing. And you would look for a sensitivity record then. That makes the sensitivity report is going to tell you what medication the agent that they cultured is sensitive to. So meaning what's going to get rid of the bacteria the quickest and most effectively is what the sensitivity report's giving you. So remember, we always want to look at the albumin level for patients who come in with wounds or have a high risk for tissue integrity problems. It's a great marker for nutritional status. And the other thing, we want to measure their ability to provide adequate perfusion. So the white blood cell, red blood cell, PTT levels are going to help you determine those things. All right, what is a pressure ulcer? So pressure ulcers are big. These are old terms, decubitus ulcer, bed sore. Those were old terms that we used to use to define pressure ulcers. Now we've switched back to just pressure ulcer. It's most descriptive of what's going on. So injury to the skin or underlying tissues over a bony prominence is how we define pressure ulcer. It has to occur over a bony prominence to be considered a pressure ulcer. So intact tissue requires only intermittent blood flow to maintain viability. So there's limited periods of ischemia that occur when we apply pressure to any part of our body. And the soft tissue can tolerate that for a short period of time before something bad happens, like a pressure ulcer. So just to explain it a little more, the metabolic rate in soft tissue is relatively low. Soft tissue, therefore, is much less susceptible to ischemia than tissues with higher metabolic rates, like the brain, for example. Due to the slow rate at which oxygen is consumed in soft tissue, a continuous flow of oxygen is not needed. So to maintain, viability and integrity. So intermittent delivery of oxygen by periodic restoration of blood flow has shown to be effective in saving soft tissue viability. So that means we can lay a person down and leave them in that certain position for a fixed period of time, but we have to reposition them in order to restore perfusion to the area that was pressure was applied to. If you don't reposition them, then that soft tissue will begin to show signs of ischemia. So what does that mean? So signs of ischemia looks like this: hyperemia. Hyperemia that is less than 1 hour, redness, due to vasodilation is what we call hyperemia. Hyperemia occurs when you apply pressure and it stays red when you reduce the pressure. So it's blanchable. In other words, you see a spot on the body that's red. It looks hot and red and mad looking, I call it. You go and you apply pressure to see if it's going to blanch. If it blanches, then that's considered hyperemia. So you've kind of got time to save that tissue if you see a blanchable redness or hyperemia. If you go beyond that stage, if it's longer than an hour that this hyperemia is there, then we're in trouble, because that will define the beginning of a pressure ulcer. So if it's not blanchable, that means it's beyond the stage of hyperemia. The blood perfusion to that area has died away. It's not going to be restorable. So at this point, so if it's longer than an hour, then it's considered a pressure area now and not hyperemia. I hope I didn't confuse you. But so if you find red spots on a body, you want to check it for blanchability. If it blanches, then that's considered hyperemia. If it's non-blanchable, then it's not. It's considered dead tissue. Whether it looks dead or not, it's not gonna be perfusing in that area where it's not blanchable. Okay. Pressure ulcers are regulated by agencies. So pressure ulcers are never events in hospitals. They should never occur. Because we can prevent them, and I just explained why we can easily prevent them by simply repositioning the patient. So if a pressure ulcer occurs in the hospital that the patient developed while in the hospital, this is considered a never event. They are not reimbursable. The care needed to take care of that patient's injury now is not reimbursable. So stage 3 and stage 4s are serious never events. And if that develops in a patient while they're in your care in the hospital, it is reportable, and they're tracked, and the hospital can be cited for injuries like that to patients. All right. So now we're going to really get into what a pressure ulcer is and how we assess pressure ulcers. So we look for their location. You're going to measure them. You look at the color, the stage, condition of the wound margins, integrity of the surrounding skin, and any signs of infection. So we've already talked about the classic signs of inflammation, and that's what we're talking about here with infection. Another term that I didn't come up in the lecture yet is called induration, and that's something you will look at with skin also. So an area of induration is where there's swelling. There may be redness, but there's swelling. And the skin will feel firm. It'll feel a little hard. in that area. And that's just a collection of fluid underneath the fat tissue of the skin. And it feels firm. It feels kind of boggy, but hard in a way, in a sense. So you would look for areas of induration also with the signs and symptoms of infection. So infection, heat, induration, pain, edema, and redness are your classic signs of infection that we're going to look for. So here are the common areas that pressure ulcers form. We've talked about pressure points. So these are all different pressure points that we'll look for, pressure ulcers on our patient. And you may have seen this already in the hospital now that we're going to the hospitals now, units. So occipital part of the head, the earlobes either side, the shoulder blades, the scapula area on the back, or the shoulders themselves, elbows, sacral area, the hips, knee, and heels. Those are most common areas that we'll see them form. It's not the only areas because we have other pressure sites that you can see them at that aren't mentioned. How do we prevent them? That's our care. If we have a patient, our goal is to prevent pressure ulcers. First, we want to identify those who are at risk. We use the Braden scale to do that. And then we're going to implement strategies to decrease their risk. And we'll go over that a little bit. So some of those things that we can do to decrease risk is outlined here. Promote nutrition, maintain skin hygiene, avoid trauma like friction, and provide supportive devices when they're needed. All right, so promoting nutrition. We want a diet high in protein, high in vitamin A, B, D, zinc, iron, promote hydration, and monitor the patient's weight and albumin levels. Okay, so zinc is really critical for wound healing, so I just want to throw that out. Deficiencies in zinc may be seen in patients who are dieting, trying to lose weight. So we need to really encourage the daily use of zinc if, in some patients, and look at their other vitamin deficiencies. Vitamin D is another big deficiency that adults have. A high protein diet is there to maintain our albumin levels, and it is a good indication of protein stores, and that's why it's a good marker for nutritional status. Protein is very needed for collagen synthesis and also for our immune function. So 2 reasons we need to make sure their protein levels are adequate. Maintain skin hygiene. So it's really, really important to keep the skin clean and dry. No excuse to leave someone sitting in urine or stool, those who cannot help themselves. You need to not put it off. It's something that needs to be removed from the skin as soon as possible, because that will lead to problems with moisture, excoriation also. So maceration of the skin erodes the epidermis layer, and excoriation will also slough away that top layer, protective layer. So we need to remove that insult right away. Clean the skin, soap and water, pat it dry, and just make sure it's hydrated and moist. Don't leave it dry skin, especially in our elderly patients. We need to make sure that we're applying lotion, just lotion, plain skin lotion. And then there are other products that we can get into that are good skin barriers to protect the skin. And you may have seen some of those already now also being used in patients who are bedbound, especially. Okay, turning the skin, turning the body to avoid excessive pressure. That's avoiding trauma. So remember, tissue loads, like I just talked about with a few slides ago. It's okay to leave a person laying in their one position for up to 2 hours. The research has shown that up to 2 hours, soft tissue will not exhibit signs of ischemia. But if you go beyond 2 hours, then you're going to start seeing signs of ischemia in areas where there was excess pressure. So we need to make sure we're turning those patients every 2 hours. We want to avoid shear and friction when we turn them. So you don't want to slide them on the bed. You want to lift and reposition the patient. The other thing you want to avoid is, especially those people who can't move themselves, avoid elevating the head greater than 30 degrees. Greater than 30 degrees creates excess pressure in the perineal area, the hip area, lower back area, thighs also. So it's not that you can't lift them that high when you need to, but you shouldn't leave them in that position. You need to lower the head back down to about 30 degrees for those who can. Frequent position change. The more frequent their turn, the better overall. And just remember not to drag them and cause shearing on the bed. Supportive devices. We have different devices that we can use to help redistribute pressure on the surface of the skin. And that's what the supportive devices are. So the mattress overlays, there are foam, gel, and air mattress overlays that you'll see used in the hospital for those who are at risk for pressure, for tissue integrity issues. Replacement mattresses. So there's special mattresses like the alternating air mattress, high, low air loss mattress. And then we have heel protectors that you've probably seen also already in use. So heel protectors elevate the heels off the bed. If you don't have a heel protector, you can still protect the heels. Simple, simple, simple. Take a towel, roll it up and tuck it under their ankles. That lifts their heels off the bed. Use a blanket, roll it up, put their heel, put it under their ankles again to lift the heels off the bed. So you don't have to have a fancy device to do this. We just need to know those people who are at risk. People coming back from surgery, for example, they're sedated. They're not going to feel the pain that occurs when you're laying in bed in one position too long. They're not going to shift their weight. So you have to do things like that to protect those pressure areas. The 4 P's is one way to think about it. Assess for pain, position, check for potty issues, and then look for perfusion problems like areas of hyperemia, for example. Okay. So again, I just talked about that. Suspending the heels. These are good examples of what can happen when you're neglectful and not assessing pressure points. And the heels are high areas of pressure injury. So you need to make sure you're checking those heels and elevating them when they need to be. Don't use donut type devices. So donut type devices, it was something that we used to use all the time. It was used to protect the sacral area on your patient. And some people will come in and bring their own donut pillow. It's a donut pillow. And they insist on wanting to use it. So we want to teach them about donut devices. They provide support. They lifted the sacrum okay, but the area that the skin sat on, that donut, was where the pressure problems developed. It applied pressure, too much pressure, and caused breakdowns in those areas. So we want to avoid using those type of devices now. Okay, so here we go again, looking at the skin. We're going to start learning how to stage pressure ulcers. So pressure ulcers are staged in 4 levels. We call actually 5 type of stagings, we can say. And to just show you the picture here of the skin is going to help you learn a little better about what each stage represents, okay? So it's a determine the depth of the injury to the skin. So that's what we're staging. How deep did the injury go into the skin? Okay. So stage 1 is a non-blanchable erythema of intact skin. So that's the patient who had hyperemia somewhere, and you went and you pressed on it and it didn't blanch. There was no break in that skin. The skin's intact outside, but underneath it, it's breaking down. So that's a stage 1, non-blanchable erythema. Stage 2. Stage 2, now we have a break in the skin, and it's called a partial thickness loss of skin. So partial thickness, it's only involving the top layer of our skin, the epidermal layer of the skin is involved. Stage 3 is a full thickness skin loss. It's now gone below the epidermal layer into the dermis. Stage 4 is a full thickness skin loss with excessive destruction. So stage 4 goes below the dermis. It goes into the subcutaneous tissue, and it may go all the way to the bone, in fact. So stage 4 is our worst pressure ulcer, and the most dangerous one. The last one is unstageable. So there's a break in the skin, you just can't see it because of all the discharge that's been produced from the wound. So you'll see all kind of stuff, yellow, tan, gray, green, brown stuff. It covers the wound bed. So you cannot see the bottom of that damaged area. You can't determine the stage, so it's unstageable. And it may have formed eschar on top. So the eschar looks black, it looks tan, it looks brown also, and it's hard. It's very hard, like a candy crust top. Okay, so that's how we stage pressure ulcers. So now we're gonna look at some. Do we have time to look at some? Yeah, we do. All right, so stage 1, this is an example of stage 1. You see the erythema. It's red in around the sacral area, and if you pressed on it, it would be non-blanchable, but it's red, it's intact. So stage 1, often you'll see them in the sacral area like this one, and it's the result from just not being positioned enough, repositioned. Stage 2, partial thickness wound. It's loss of the top layer of skin. So the epidermis, it's almost like an abrasion, you know, someone comes in, the top layer got scraped away. That's kind of what you're looking at, a stage 2. Now, remember, all these wounds that we're talking about, pressure ulcers, they are occurring over a bony prominence. So it has to fit that definition also. So stage 2 often looks shallow, like a crater abrasion. Blisters are considered stage 2 pressure ulcers. All right, stage 3, it's a full thickness wound. It's below the epidermis now, so all the epidermis is gone. We're looking at the dermal layer of the skin, and you may see the subcutaneous tissue, and that's pretty much what clues you in that this is probably a stage 3 ulcer. So it's a deeper crater, and it may have what we call undermining. Undermining is when you look at the edge of the wound, and this is not a picture of undermining, but under the edge, you'll be able to stick like a toothpick or your finger underneath it. It forms like, I call it the roof. That's the undermining in a wound. So stage 3 ulcers can start developing this type of observation, undermining, and other things, but that's common in stage 3. Stage 4 pressure ulcers. Stage 4 again is our worst stage. It goes all the way to the muscle, and in some cases the bone. You'll see the bone. Stage 4, the biggest problem we worry about with stage 4 ulcers is osteomyelitis because the bone is exposed, and it's easy for bacteria to get in there and damage the bone. And that's a very difficult infection to treat. Anyway, so here are examples of undermining, like we just described. On the right-hand side, what is undermining? It's the destruction of the underlying tissue surrounding some or all of the wound margins. It may extend in one or many directions. So when we would describe undermining, you would want to make the wound the face of a clock. And then you would describe the undermining based on the numbers on a clock. So like for this one, it's from 12 o'clock to about 3 o'clock, the undermining. And you would want to measure how deep it is. So we could do that with a sterile Q-tip, and you just go in, and when you pull it out, you can measure how far it went in. And you measure the deepest point. You don't measure all over the place. Then the other side on the left is tunneling. So tunneling is also something that happens with stage 4 ulcers. It can happen with stage 3, but most of the time you'll see tunneling with stage 4. So a narrow opening or passageway that can extend in any direction through soft tissue and result in dead space with partial or abscess formation. It's called a sinus tract, okay? So again, you would take a toothpick, a sterile toothpick, and you would go in as far as you could to try and measure how deep the tunneling takes place, and you would describe it again with the face clock where the tunneling is in the wound. Let's see, where are we? Okay. So we're going to get into cleaning and treating ulcers now. The pressure ulcers, can't get it out, and different types of dressings that we can use to treat pressure ulcers. And so it's kind of a lot to go through in a few minutes. So why don't we go ahead and take a 10-minute break right now? It's 9:18. So in 10 minutes, y'all return and we'll continue and finish up with pressure ulcers and move on to our next topic. Okay?
Okay, we got it. Thank you.
All right.